Yes.
I will be speaking on the applied anatomy of the cornea, the sclera, and the conjunctiva. First, let's start with the cornea. The cornea is a spheroid, and as any spheroid, it can be of two shapes. It can be oblate or it can be prolate. Oblate means that it is flat at the center and steep at the poles. And oblate corneas are seen in animals like frogs. Whereas prolate means that it is flat at the poles and steep at the center. And prolate corneas are seen in animals with superior vision like eagles. So we humans are very lucky to have prolate corneas. Next, the size of the cornea. For practical purposes, what we do is we measure the horizontal corneal diameter using a caliper. And if the horizontal corneal diameter is less than 9 at birth or less than 10 after 2 years, it's called as a microcornea. If it is more than 11 at birth and more than 13 millimeter after 2 years, it is called as megalocornea. Then all infants with megalocornea do rule out congenital glaucoma. The thickness of the cornea is thinner centrally than peripherally. And this is especially important when you are measuring the intraocular pressure, because if the central corneal thickness is low, you get a lower intraocular pressure, and in thicker corneas, you get a higher intraocular pressure. So if you do not take into account the central corneal thickness, you may err in your diagnosis of glaucoma. I'm sure all of you know the layers of the cornea. Embryologically, the epithelium is derived from the surface ectoderm, from where the skin and hair and nails are also derived. So just like them, it can regenerate. Whereas the endothelium, which is from the neural crest cells, once lost are lost forever. The corneal epithelium is stratified, squamous, non-keratinized. The youngest cells are at the bottom, the columnar basal cells. Then comes the wing cells, and the oldest cells are compressed at the top, the surface cells. And all these cells have innumerous intercellular connections. These include the tight junctions, the desmosomes, and the hemidesmosomes. So all these together constitute the epithelial barrier, and it is this epithelial barrier that prevents the entry of water, molecules, and microbes into the cornea. And this is why when we do a fluorescent staining, we find that the fluorescent stains the tear film. However, the cornea does not stain. But if the epithelial barrier is breached, the fluorescent will encounter the higher pH of the stroma and it will take up the stain. Similarly, if you have an abnormality in your desmosomes and hemidesmosomes, you are likely to get recurrent corneal erosions. So I've told you that the epithelial cells regenerate, and how does this take place? There must be a source. And the source of the epithelial cell regeneration are the pluripotent stem cells, which are located at the limbus in horizontal ridges called the palisades of Vogt. And how does this regeneration takes place? In the first step, the limbal stem cells will migrate horizontally to the center and form the basal cells. In the next step, these basal cells will divide by mitosis and move vertically and become the surface cells. At this point, the older surface cells will desquamate into the tears. So this three-step process is called the XYZ hypothesis, where X is the vertical migration, Y is the horizontal migration, and Z is the loss into tears. So for your normal corneal epithelial function, Z must be equal to X plus Y. However, in conditions like limbal stem cell deficiencies, horizontal migration is affected. And so there are persistent epithelial defects and conjunctivalization of the cornea. Similarly, in epithelial dystrophies, the vertical migration is affected and the cells can no longer desquamate into tears. So they become intraepithelial cysts. That concludes the epithelium. Next is the Bowman's membrane, which is the anteriormost part of the stroma. The Bowman's membrane, once injured, cannot regenerate. So any disruption or a wound or an ulcer will result in a corneal opacity. The stroma constitutes 90% of the thickness of the cornea. It is comprised of collagen, glycosaminoglycans, and cells like keratocytes. The collagen is type 1 and is arranged uniformly in lamellae. And this is very important because that is why the cornea is transparent. The cornea is transparent because the collagen fibers are uniformly arranged and the distance between these fibers is less than the wavelength of light. So that if there is any raw ray, it is immediately destroyed by destructive interference. And another feature about the packing in the stroma is that in the anterior stroma, the collagen fibers are very tightly packed, whereas in the posterior stroma, it is less so. So if ever there is any edema, the fluid is unable to move anteriorly. So it goes posteriorly. This results in undulations in the Descemet's membrane, and these are seen as Descemet's membrane folds. How does a stroma repair itself after injuries? It is by activation of the keratocytes, which migrate to the site of injury, transform into fibroblasts, and produce scar tissue. And if there is at all any interference in this process, it will result in a corneal melt. The Descemet's membrane is thin but very strong, and it can maintain the integrity of the cornea even when the stroma is lost, such as in a descemetocele. Here are two conditions where the Descemet's membrane is damaged. Here, this is a complication of cataract surgery. You can see an area of focal edema, and if you zoom in, there is a Descemet's membrane detachment. And here you can see an ectatic cornea with surrounding haze. This is due to rupture of the Descemet's membrane that occurs in acute eye drops. So in both these conditions, you can find that the Descemet's membrane is damaged, but in most of the time, it can be resolved with conservative treatment. This is because of the ability of the endothelium to synthesize fresh lamina identical to the Descemet's membrane. The endothelium, at birth, we have about 3,500 cells. It decreases every year by 0.6%, and by adulthood, we have about 2,400 cells. And the endothelium is important in maintaining the corneal transparency because of the presence of pumps which constantly pump water and solutes out of the cornea and maintain the state of relative dehydration. So if your endothelial cell count falls below 500, you will get irreversible corneal edema. So how does the endothelial cells heal? As I've told you, it cannot regenerate. So what happens is if there is an endothelial damage, the surrounding cells will enlarge and it will fill up the deficit. And this enlargement of the cells is called as polymegathism, and the change in the shape as a result is called as pleomorphism. So here you can see dimpling of the endothelium, and on specular microscopy, there are dark gaps. These are guttae, characteristically seen in Fuchs endothelial dystrophy. And here is a dreaded complication of cataract surgery, an edematous vascularized cornea. This is pseudophakic bullous keratopathy, occurs after prolonged, difficult surgery, especially in those with low endothelial cell count. So it's always prudent to look at the endothelial cell count before surgery. Finally, just a few words about the pre-Descemet's or Dua's layer described by Dua and his colleagues in 2013. They found that just before the Descemet's membrane, there was a layer which was very strong, acellular, impervious to air, and could withstand high pressures. And they call this the pre-Descemet's or Dua's layer. And they said that by including this layer in lamellar corneal surgery, we could vastly improve our surgical outcomes. Finally, about the blood supply and innervation of the cornea is avascular except for at the periphery, which is why in immune-mediated diseases, we get peripheral corneal ulcers because the antibodies can reach only the periphery. They can't reach the center. So the antigen-antibody complexes are formed in the periphery, which results in corneal ulcers at the periphery. And the cornea is richly innervated, which is why never underestimate the pain of a corneal epithelial defect. So next, the limbus. I'll be just mentioning a few words about the surgical limbus. So the surgical limbus is a 2 millimeter wide zone, and it has the following landmarks. The anterior limbal line corresponds to the termination of the Bowman's membrane. The mid-limbal line corresponds to the termination of the Descemet's membrane or the Schwalbe's line, and the posterior limbal line corresponds to the scleral spur. Between the anterior limbal line and the mid-limbal line is a blue zone. The blue zone is widest superiorly. Between the mid-limbal line and the posterior limbal line is a white zone. The white zone is 1 millimeter throughout. So in whole, the surgical limbus is widest superiorly, which is one of the reasons why the superior incision is so popular. So on surgical section, this is how it looks. And this area is the blue zone. And here you have the white zone. This coming to the sclera. Both sclera and cornea are composed of collagen. However, the cornea is transparent while the sclera is not. This is because of the irregular arrangement of the collagen in sclera, leading to scattering of all the wavelengths of light, giving it an opaque appearance. The sclera may not always be white. Blue sclera is seen in collagen disorders like osteogenesis imperfecta and Marfan syndrome. Yellow sclera is seen in conditions like jaundice. Yeah, but physiologically also, sometimes in children, you can get a slight bluish discoloration of the sclera. This is because of the thinness of the sclera And in elderly, sometimes you may get an yellowish discoloration. This is because of the deposition of lipids. The thickness of the sclera is thinnest at the insertion of the extraocular muscles and at the limbus. This is why in trauma, the globe rupture, the common sites are at the insertion of the extraocular muscles and the limbus. And while doing a surgery, whenever you're passing sutures close to the extraocular muscles, do be extra cautious. Remember, this is very thin. The blood supply and innervation of the sclera. Sclera is relatively avascular. Whatever supply it receives, it's from the episcleral bed and the choroidal vasculature. And the contribution from the episcleral bed is slightly more, which is why the anterior scleritis is more common than posterior scleritis. Again, sclera is very richly innervated. This is why in scleritis, there is severe pain that wakes the patient up from sleep and does not respond to analgesics. And it is because of the extraocular muscle attachment to the sclera that there is pain on extraocular movements. And what happens to the sclera whenever there is raised intraocular pressure? In infants, it leads to the stretching of the sclera, leading to bullseye or ophthalmos. In adults, the scleral is more rigid because of the increased collagen diameter. So what happens is at the lamina cribrosa, where the optic nerve fibers, here it bows backwards, and this results in optic disc cupping. We finally come to the conjunctiva. The conjunctiva, mainly three parts: the bulbar conjunctiva, the phoenicial conjunctiva, and the palpebral conjunctiva. The bulbar conjunctiva is very thin. It is loosely attached everywhere except at the limbus, where the conjunctiva, tenons, and sclera fuse. This is why surgeons love to hold at the limbus. The phoenicial conjunctiva is loose, flexible. It is what provides motility to the eyelids and the eyeball. So whenever there is any symblepharon, such that is any adhesion between the palpebral and bulbar conjunctiva, the fornix is obliterated. So there is decreased motility and also dryness and keratinization. The palpebral conjunctiva is thin, very vascular, and has fibrous septa anchoring it to the tarsus. It also has the highest number of antigen-presenting cells, which is perhaps why there are conditions like papillae. Papillae are elevated, flat-topped lesions with a cobblestone-like appearance. They are red at the bottom and pale at the top. And they're characteristically seen in allergic conjunctivitis and also in contact lens users. Another condition is follicles, which are discrete nodules. They're red at the top, pale at the bottom, and they're characteristically seen in viral conjunctivitis, so can be seen in bacterial conjunctivitis also. The sulcus subtarsalis is a groove 2 mm from the lid margin, and it is the most common site of lodgement of foreign body. So always evert the upper cell conjunctiva before saying there's no foreign body. The conjunctiva also has some vestigial parts, just like the appendix. These are the caruncle and the plica semilunaris. They are remnants of the third eyelid or the nictating membrane seen in birds. So in birds, this nictating membrane helps them to keep the eyes open while flying. The histology of the conjunctiva: there is the fibrous layer at the bottom, this fibrous layer which contains the accessory lacrimal glands. Then there is the adenoid layer which contains the conjunctiva associated lymphoid tissue, which is responsible for mucosal immunity. And finally, the epithelium. The epithelium contains the goblet cells which secrete mucin. And it is this mucin that provides stability to the tear film. So any loss of goblet cells, you will get ocular surface disease and severe dry eye, such as in xerophthalmia and Stevens-Johnson syndrome. So I hope I've said just the right amount, not too much, not too little. Thank you.